So transmission, this is, it actually doesn't compare from the pathogenicity aspect with SARS and MERS because they had much higher fatality rates. But this seems to spread much more, well, it does spread much more rapidly. They didn't spread hugely in the community, these have. But so even though the death rate is much lower, it's still, because of the number of people affected, hugely significant for us. Okay? And at the moment, as I say, the R0 is about 2.5 to 3 people. So what we need to do is stop the spread. This is that microbiologist in New Zealand again, and the green, when you see the green one come up, that's us doing nothing. And the line across there is healthcare system capacity. So if we all do nothing, apart from stock roll toilet paper, we collapse quickly. If we do what we're doing now, strong collective response, then it goes up and then it starts to decline. And at that point, you hope maybe vaccines got in, or you can work out that a lot of people have had it. The worry is if we aren't getting this collective immunity, then we stop doing everything and it goes down and everybody then thinks, oh, it's fine. And then off we go again and the healthcare system then collapses at the end of it. So, we're still in the finding out phase, but the antibody test, I think, is going to be so useful for us going forward and probably will change what we're going to do. So when Boris said it'll all be over in 12 weeks, I don't think he actually did say that. It was interpreted as that. I think he's saying within that period, we will know where we're going. Okay. So to work out the R0, you look at things like how it's actually transmitting. And the good news is, and I probably should have pointed out on that other chart, that if this is coughing, not sneezing. Sneezing is a cold. This is coughing. So coughing means it doesn't go very far. If you sneeze, aerosols go everywhere and you get little infectious particles. But a cough, really, most of it is big lumps that drop within a couple of feet. Sorry, old money. But small infectious droplets, 3 to 5 feet, so 2 meters. A sneeze would go into the air and kick around. Now, if something's spread by sneezing, it has a high reproductive factor because it kicks around in the air and then people can pick it up. So at the moment, it's 2.5 to 3, similar to the pandemic flu, which is 2.8. So that tells us it's droplet. Okay. Things that are more airborne, like chickenpox, you take your kids around to see other kids. Infectivities, 4 to 5 children will get it from an infected person if they're not vaccinated. Compare that with measles, which really is airborne, 12 to 18. So if it was 12 to 18, we would all be wearing respirator masks, but it's not. So that tells us what we need to do. So it's respiratory droplets and direct, indirect contact with infected secretions. And that is generally within a couple of meters. Now, if you're unlucky enough to be 2 meters from somebody, within 2 meters of somebody, when they cough, you might get some onto your own mucous membranes, which is why you wear some protection, okay? But you're not going to inhale it, it's just going to land on the surface of the mask, okay? But of course, if there's no one within 2 meters, what I'm coughing out contaminates the surfaces around me. And people touch those and then they self-inoculate themselves. So that's the other thing. So that surfaces are a potential reservoir and have been in all of the outbreaks over the years, but if they're not destroyed. So that can be done through chemical methods, through disinfectants and soaps, or it can be done through physical methods, like if it dries. So they do not survive very well on porous surfaces because the moisture gets absorbed, that leaves the virus pretty much exposed and it does not like it. So when somebody coughs, you don't cough out little viruses, you actually cough out lumps with the virus in it. Yeah. UV light, though, is very good at destroying these viruses. Sunlight is fantastic. A couple of hours of sunlight is very effective against these viruses. And the maximum transmission risk is from people is when they first become viremic, when they're first getting symptoms. That's the same with any viral illness. When you're first showing symptoms, that's when you're the most risk, because you have huge amounts of replicating virus and you're much more likely to transmit it. Okay. To show how much these respiratory viruses are around, we come into contact with them all the time. If you travel on public transport, you've got an increased risk of about 6 times, unless you do it a lot, in which case you have less risk because you've been exposed more often, so you get immune. We talk about air travel, okay, and it's quite interesting, air travel, because it's not just the person on the plane who flies from A to B, it's also why the plane goes. So I was in the Gambia back in February, and because I'm a geek, I look on flight radar, which tells you where your plane is, but you can also see where the plane's been. So while I was flying from the Gambia back to Manchester, that plane had been to Italy 3 times, to Austria, to Switzerland, to Greece a couple of times, and then to to other countries in that time, because they're just little buses that shuttle all over the place, and they don't just go from A to B, they go X, Y, Z, etc., etc. And as you know, a modern low-cost airline has fantastic cleaning procedures between everybody that involves opening the back end door and the front door and getting everybody off, and maybe picking up the newspapers. Now, most surfaces on a plane are actually porous, like the seats and that sort of thing, so probably less of a problem. You don't touch those. But the thing you do touch is the tray in front of you put your food on, which is a hard plastic, and that's what these viruses survive best on. You're talking days. So I have to say I tend to wipe the tray when I go on the plane. Now, actually, somebody did some work in an airport just to see what surfaces are contaminated there, because so many people travel around the world through the airport, and the most contaminated thing is the baggage screening tray, because everybody touches it and it's made of hard plastic and it is never cleaned. So just think about that when you go to the airport, because you get your stuff screened and you think, thank God it didn't go down the other side where I'm going to find one lip salve after about an hour. So you're so relieved, you go off to get a coffee and a muffin. Do you clean your hands before you do that? And you've touched everything. Maybe think about it. Anyway, so how do these viruses actually get to us? Well, they survive very nicely in the environment if you haven't been actually coughed on, but a mode of acquisition is not inhalation, it's intranasal inoculation, which we do a lot because we do this all the time. And this was a study where they told some medical students, we are going to be watching your hand contact during this lecture, and even then they still did this 23 times an hour, because you can't help it. Because people do this, and it's just human nature. It's what we do. Some people do it a lot. What we have to be very careful about is we're not doing it while we're working in healthcare. Okay, it's not a great habit to be in anyway. But you know, if you're wearing PPE, you really do not need to be touching your mouth or eyes or anything like that, because the environment does become contaminated. Now, this is a MERS outbreak in Korea. Korea does not have an enormous camel population, especially in the hospitals. But what happened was a chap from Saudi Arabia who was not well flew to Korea, and when he got there he felt really terrible, so he went to the hospital, and after 5 hours he got bored, so he went to another hospital. He sat in A&E, nobody did anything with him, so he caused outbreaks in both hospitals. Now, it's not his fault. I would say the cleaning procedures and the infection control procedures in these two hospitals were not good, but they were big outbreaks in both hospitals. Because he was coughing up, and actually, but afterwards, of course, they do some studies, and they looked at patients with MERS. And don't forget, you up the cleaning supposedly if you've got somebody with a respiratory virus or there's an infection, and they still found viable virus on about a fifth of all surface swabs. So that's things like stethoscopes, because they're self-cleaning, aren't they? Ambu bags, call buttons, keyboards. You see, people work with the gloves and then they take the glove off, so they think, I don't need to clean my hands. Well, and then they go to the keyboard. But that's there for the next person. That floor I'm not too worried about, to be honest, because shoes aren't, you don't come into contact with them very much. So people just weren't doing any cleaning. And cleaning just works. It's so easy. Because these things are envelope viruses. And an envelope virus means it's got an oily, waxy layer around it called a lipid layer. So you just break that apart and that's it. Game over for the virus. So really easy. This is, to kill. And some soaps will do it actually if there's a reasonable amount of surfactant in them, but most disinfectants are absolutely fine against this. And the wipes we use here are fine. 1,000 parts per million chlorine is fine, but fixtures and fittings, things we touch, are a significant risk. And I know there was a story last couple of weeks ago going about it's petrol pumps. Well, they're out of doors and probably getting UV light a reasonable amount of time. But what you do touch is, because who spends less than 30 quid on fuel, is the keypad when you're doing I can't use contactless. Everybody's using it. So I know they've upped it now, haven't they, I think? So that was a good thing to do. So surfaces become contaminated because of directly from coughing and sneezing. But then what happens is the staff are working in their area, close contact, that's all fine. Oh yeah, I need something from over here. So you go over there and you touch something there and you've contaminated it. And the next person then thinks, I'm not 2 meters away, I don't need to wear gloves, and they contaminate themselves. So think about what you're touching, Contamination is greatest if you're having to do an aerosol generating procedure, and I'll tell you what that is in a minute, because there's chance of it aerosolizing, so therefore a little bit more spread. But in significant numbers on surfaces, we think less than 3 days probably. It depends on the surface. As I said, plastics, so they'll survive longer on, and then metals, and then porous surfaces not particularly long. You will see the odd study that says we detected it after 10 days, but that's done in the laboratory under completely controlled conditions of not particularly high humidity, and high humidity does not do these viruses any good either. But the good news is they're easily removed by cleaning. As I say, chlorine's fine, and the wipes that we use are absolutely fine as well. What we do with the waste and laundry is exactly what we do for any other infected patient. So orange bags for the waste. Laundry goes as infected laundry because then it's not handled when it gets to the laundry. Body fluid spills, as the usual policy. Uniforms, what we should be doing anyway, because you will be working with people with infection that we don't even know about. Not COVID, but other infections. You know, just try and wash your uniform separately if possible. Don't overfill the machine. I know we'd like you to wash it over 60, but you know, probably 40 with the dilution factor, and the soap is going to be okay. If you hang them out to dry, the UV would kill everything anyway, and ironing will definitely sort out anything on your uniform. So I'm not worried about it. You know, if you've got somebody in the house with flu, you don't wash their clothing separately, do you? So it's exactly the same sort of principle. The dilution and the water changes would sort that out. Please don't forget about patient hand hygiene is very important because they don't do it very well. They're even worse than the orthopedic surgeons. So after coughing and sneezing, before eating and after the toilet, if they've got a hand wipe there, you have to prompt them. I'm actually doing some research on this with colleagues at the University of West London. You can put things in front of patients, they do not use them. Yeah. So all the hand wipes go back to the kitchen, which is a huge waste. Just say, would you like to clean your hands and open the wipe for them, or give them the alcohol gel and ask them if they would like to use it.